Very good evening to one and all. Welcome to Dehradun. So today my topic is going to be to incorporate Toric IOL in your practice, all you need to know. So we're going to be dealing with the absolute bare basics of Toric IOL and how a youngster or somebody who is experienced and hasn't taken up Toric in their practice can do so. Welcome to Dehradun, and I would like to thank the staff back at my hospital who have helped in some or the other way in making this presentation. The most important point that ma'am also mentioned in her talk previously is patient selection. So if we are planning to go ahead and do and give a wow factor to our patients post-op day one, we have to be sure that we have chosen the patient who would appreciate that wow factor in the first place, right? If we don't choose that patient who would appreciate that wow factor, all of your planning, all of your execution will go in vain. So what about the patient selection? You have to go methodically. Vision, manifest diffraction, a thorough slit lamp examination, dilated fundus examination, optical biometry, a topography. It should be regular, stable and symmetric. Current evidence suggests that the minimal amount of corneal astigmatism of approximately 0.75 is to be corrected. So as sir was mentioning before, if you have a regular bow tie astigmatism, that is going to be the most suitable. An irregular astigmatism is a relative contraindication. It is shown to be effective in patients with irregular astigmatism, including keratoconus, pellucid marginal degeneration, and post-keratoplasty eyes, if on the pentacam the EKR values from 2 mm right up to 6 mm are pretty much the same, and there is not much more than a 0.5 jumping of the values from 2 mm to 5 mm of the cornea. So Toric IOL calculator. So you have now selected the patient that would appreciate the fact that you're putting a Toric IOL in the eye. Now you go ahead with the calculators. There are all sorts of calculators that are available. Each company also has their own calculator that is there. So you have the online calculators. You need to determine your own SIA as was mentioned in the previous talk and include PCA. So this is the universal sort of a Barrick calculator that you can use for any lens that you are putting, any brand that you're putting, because the algorithm of the Barrick style calculator has the most amount of data that is there. So you have the patient ID, you can choose any of these lenses that is there, and this is how the printout of what you're going to be implanting in the eye is going to come out. So in this particular case, you can see it's the left eye, and the calculator is telling you to implant it at 174 degrees. So now that your calculation is done, you see that what is the toric power that is to be implanted. You see at the left corner there is the T2 to T9, and you have different lenses, different companies, all of them from T2 to T9 will be different. So you need to customize it for your particular patient according to the lens that you're going to implant, according to the brand that you're going to use, that which one from T2 to T9 that is the one that you're going to be using. So the advantages of the Barrett Toric IOL calculator are very easy to use, takes into account the posterior cornea as well. It also considers lens position for each individual patient versus using what is known for the average eyes in a lot of formulas. Lens thickness is measured, which helps in even better predicting. So the thing is that some people say, I don't have an optical biometer. Now, can I go ahead and do a toric? Yes, of course you can go ahead and do a toric. The more data that you will enter in the Barrett's formula, the more accurate your result is going to be. But that does not mean that if you don't enter everything, you're going to get a very, very inaccurate result. So if you don't have lens thickness, for example, if you don't have an optical biometer which is giving you a proper ACD, you can still omit the ACD part of it. You can put the lens thickness from your contact, you can put it from your immersion, and you can have all that data into the system. It will still give you what angle, what degree it is meant to be implanted in. So this is how the Technis Toric calculator looks like. You first basically select the eye, you give the K notation whether you want it to be in diopters or millimeters, you make sure you have the correct eye. Once that is done, you enter your SIA, you enter the axis and the incision. As was mentioned, the incision that you take plays a huge role in toric surgery. You can always alter your position, you can sit superiorly, you can sit superior-temporally, you can sit temporally, depending upon where the steep axis is. Once all this has been entered, You take your readings from whichever K machine that you are using, either the ARK, that also works fine if you don't have a topographer. And then you'll get something like this. This is the final result that comes in, and it tells you how much of the residual astigmatism will be left behind. So here then you choose. You see here at the bottom, you choose which one do you require, which one are you going to be implanting. This again depends upon how much residual cylinder is going to be left behind. So now that you have done the calculation, you have chosen your patient. What next? So next is going to be the instruments for marking the toric. So this is a typical instrument marker, the set that is required. So what we do in our practice is we do a two-step procedure. First we do it in a sitting position on the slit lamp in the OPD, and then again on the table. So we do it in a two-step manner so that errors are omitted. You can choose, you can use these markers. You can mark your axis marking rings with these markers so that the imprint stays onto the cornea. The axis marking has to be in upright position to prevent cyclotorsion. The cyclotorsion of the eye, just a second. Anyways, the upright position to prevent cyclotorsion. The cyclotorsion of the eye from the upright to the supine position is approximately 2 to 4 degrees on average, but can be up to 15 degrees in individual patients as well. So the three-step marking procedure, the first is pre-op, the second is again pre-op, marking at the limbus at the horizontal position with a sterile ink pen or a needle. You can use a 26 gauge needle as well, but initially I would say you use a marker and not a needle, but once you do get a hang of it, then you start using a 26 gauge needle. The third step is intraoperatively on the table. We have the image guidance systems also, but even in these systems, it has now been determined that in a lot of these, what happens is that if, for example, the blood vessels that have the machine has taken into incorporation to have this axis that it is giving you, if that blood vessel becomes skewed, then this can go haywire. So it is always a good idea to even mark this manually, even though you have the Virion system. So the sources of errors can be an error in planning, error in measurement, and error in execution. Errors in planning can rule out causes of irregular astigmatism, as I mentioned earlier, comparable magnitude of axis of astigmatism on refraction, biometry, and topography. If these are not matching, that's a red flag sign. Consider posterior corneal astigmatism as well and use aberrometry where possible. So this is a very important slide, errors in measurement. So you see all these machines are there. We started way back with this, what used to be the gold standard for a very long time. Then we went on to the IOL Master 500, which took about 6 points of measurements. Then we moved on to the Lens Star, which takes about 16 points of measurements in the center. And now we have moved to the swept source. So are all these machines the same? Well, there are errors in measurements in all the machines. What is most important is, you see this, how this makes a huge difference. We let our technicians do these tests for us. We don't do it ourselves. So you see just the position of the chin, just the position of your head, how much error it causes. Same patient, 1 minute apart. On the top you see an astigmatism of 0.9, in the middle you see an astigmatism of 1.4, and at the bottom you see an astigmatism of 1.9. Same patient, 1 minute apart. What was different was the position of the chin, position of the head. So this is extremely important, because this error, you can't predict it, and you won't be able to solve it later on as well. So errors in execution, of course, errors in marking. When you do it initially, there can be an error that can happen initially. So you need to be very careful that the patient is cooperative on the slit lamp when you're doing the markings on the sides. To summarize, online calculator, reference marking, rexis marking, axis marking, alignment, rotation, and vaulting. Most important, patient selection with what I started with. If you do a toric calculator and you end up having an issue, you end up that the toric has rotated, there is this website called astigmatismfix.com. You can go to that website. It's not like, for example, if the toric has rotated by 10 degrees or 12 degrees, you can go back into the OT on post-op day 2, day 3 and rotate it back to that. No, you can't do that. You have to go to astigmatismfix.com. So I have basically just taken this screen recording for you. So what happens here is that you enter all this data. Once all this data has been entered, you click on calculate. It takes into account a lot of things. It takes into account the cylindrical power at the corneal plane, what the current IOL access is, and also takes into account what the current refraction of the patient is post-operatively, how much of astigmatism is the patient accepting now post-operatively. Once you've entered all that into your astigmatism fix, then it will basically tell you, you click calculate and it will tell you how much you're supposed to rotate it by so that the patient gets clear vision. So these are a few commercially available IOLs that are there in the market. Thank you so much.
The most important thing as a beginner, I think so, is that the message across is you don't need many fancy gadgets. It's how you are going to do the keratometry. So it's always advisable to do the keratometry first thing when the patient comes. After you have done all the contact procedures, you're going to get an erroneous keratometry. Second thing is, through a manual keratometer, you look at the Myers. If the Myers are circular, you are most probably, and both the axes are at 90 degrees, you are dealing with a regular astigmatism. So you can go ahead and do a toric, because PCA is already incorporated in the Barrett's formula. And in CN, you can always shift according to how close you want to go to the steep axis. And marking is beautifully highlighted. So there's one app actually available known as iToric. Once you do the marking, you just go, it's a mobile based app. So you just click on that and it will tell you how much of your marks have missed. So how much do you need to realign that? Suppose you are supposed to align that IOL at 6 degree and your 0-180 degree has missed by 2 degrees, it will tell you automatically. So it's a very good app, the iToric. You can use it once you have done the manual marking on the this slit lamp. Just it's a mobile based app, it will click a photograph and tell you how much you have deviated. Any other questions?
Right. Thank you, Dr.